Well, good morning, everybody. Boy, do I have a treat for you this morning. This is really it's a special morning for me. Dr. Michael Fine and I grew up together in a small town in New Jersey called Glen Rock, and got reintroduced to each other years later and figured out that we were kind of doing the same thing and both interested in the same stuff. And how two radical people came out of that town still completely astounds me. But he has gone on to become an award-winning author, a community organizer, a public health expert, as a family doc, probably his most important credential. He serves as chief health strategist for the city of Central Falls, Rhode Island. He was the director of the Rhode Island Department of Health for 4 years between 2011 and 15. Before that, he was a medical program director at the Rhode Island Department of Corrections. He was founder and the managing director of Health Access Rhode Island, the nation's first statewide direct primary care organization, which made prepaid primary care available to people without employer-based health insurance. Dr. Fine practiced for 16 years in family medicine in Rhode Island. He was the physician operating officer of Hillside Avenue Family and Community Medicine, the largest family practice in Rhode Island, and was physician-in-chief of Rhode Island and Miriam Hospital's Department of Family and Community Medicine. He founded the Situate Health Alliance, community-based population-focused nonprofit organization, which made Situate, Rhode Island, the first community in the United States that provided primary medical and dental care to every one of its town residents. Dr. Fine is also co-chair of the Allied Advocacy Group for Integrated Primary Care and convened and facilitated the Primary Care Leadership Council, a statewide organization that represented 75% of Rhode Island's primary care physicians and practices. He currently serves on the board of the Loan Institute, Rhode Island Communities for Addiction Recovery Efforts, and the Situate Health Alliance. He's also a short story writer. And once every couple of weeks, those of us who are fortunate enough to have found out get a very interesting short story sent to us by email that Michael's written, and always has some very powerful message associated with it. In short, he's an amazing person with an incredible set of skills. And I'm sure that you're gonna love this very unique look at the work that we do. And while we're doing such great healthcare, how we're contributing to the damage to the very communities that we serve. So Michael, take it away.
Thanks, Neil. I can't tell you what an honor it is to be here and to receive that introduction. And I'm hoping that this loads up and is ready to go. Let's see. Is it looking right, or does it need a little attention?
Looking good. Just hit slideshow.
All right.
And
hang on, it's being a little, okay, we got it. Okay. From beginning, we're good. Okay, that should take a second, be ready to go. But again, thank you. Neil was always the guy. I hate to acknowledge this, but Neil's a couple of years older than I am. And
hey.
he was always the person that I looked up to. You know, he was older enough to be the kind of leading edge, and to watch what you guys he has done and you guys have done in the Institute, and how important a role that is nationally, and what's happened nationally as a result of your model. It sort of blows me away that A, that it's happened at all, and B, that I have had the honor of knowing Neil a good part of my life. So, you know, how cool it is for me to be able to be here with you this morning. I don't know if this is running right. Is it looking right to you guys, or?
If you hit slideshow at the top and then show
from beginning. Yeah,
yes, exactly. That'll be good. That'll do it.
Let's see if it will. Okay, let's try this. Okay, we got it. Yeah. So this is the story of a book I wrote when I got mad. It's really the story of two communities. And and some basic facts that I learned in the process of working through being mad. The two communities are Situate, Rhode Island, which you heard about, an ex-urban place of about 10,000, mostly nurses and teachers and firefighters and police. Beautiful place to live, where the state's water system actually is centered, where all the reservoirs are. So we have a bunch of protected land. It's as beautiful a place as you can imagine, and but it's also the most Republican place in the state. However, it is the only place in the United States, as you heard, where everyone's guaranteed access to primary medical and dental care. The other community I'm going to talk about is Central Falls, Rhode Island, which is the state's smallest, most densely populated, poorest, and most diverse community. It's about 80% people of color, 70% Latino, about 50% non-English speaking, and has half the state's Cape Verdean population. We have a population of about 20,000 folks mostly from the island of Brava in Cape Verde. So we have a considerable language diversity. And Central Falls became, probably because of its densely packed population and the number of people who live both in poverty and packed into what we call triple deckers, 3-floor old wood frame apartment buildings, we became the most infected place, COVID infected place in the state, in the nation, and for periods of time in the world. I have no commercial disclosures. On goals and objective side, we're going to go through some public health outcomes associated with primary care practice, a bunch of different stuff, which you'll hear as we go. The talk is always in memory of Jack Geiger, who, as you all know, I suspect, was the founder of the Community Health Center in the United States. But just to remind everybody, there are 14,000 community health centers functioning at 14,000 sites and providing the best measured primary care to 30 million Americans, which proves to me that, government may be a problem some of the time, sometimes even most of the time, but it can still be used in the service of the public's health. Now, I started the pandemic knowing 4 key facts. First, and you guys know this, the U.S. In the U.S., we spend an egregious amount on healthcare, $4.3 trillion or more in 2021, about 20% of GNP, twice the average cost of other developed nations, 60% more than the nations with the best outcome, costs that rise about twice the average rate of inflation, and about $13,000 per person per year. Now, I contextualize that with looking at Situate, because the population's a nice round number of 10,000. That's equivalent, for those of you who are in the city, to about 7 city blocks, about 10,000 people. That means for every 7 city blocks, or for the little town of Situate, we're spending $130 million a year for the healthcare of the people who live here. Now, by comparison, I go to the financial town meeting every year. The budget for the town of Situate, for everything else we spend, is about $40 million a year. So we're spending 3 times on healthcare what we spend for education, what we spend for police and fire and EMS and garbage pickup, every other thing that we spend we spend public funds on. We spend 3 times that on healthcare alone. Now, that matters, not just because it's a lot of money, but because if you look back over time, as we kept spending more and more on healthcare, we spent less and less on the public services that matter for health outcomes. So our housing assistance has dropped to the floor. Our spending on education has dropped. Our spending on public transportation has dropped. All of which, you can't say it's a direct transition, but money that we're spending on healthcare is money we're not spending on the things that matter for health. Second key fact, and again, I think you guys know this, our life expectancy I don't know the nicest word, but the nicest word I'll come up with, our public health outcomes suck. By comparison with others, we are between 46th and the 50th in the world for life expectancy and infant mortality, and we have outrageous health disparities. You know, our life expectancy for Black Americans is 4.5 years, shorter than white Americans, 11 years shorter than Asian Americans. Our infant mortality rate for Black Americans is 3 times greater than for white Americans, and our average infant mortality is 3 times greater than the best achievable rates in the rest of the world, which means that the infant mortality rate for Black Americans is actually 9 times greater than the best achievable rates in the United States of America in 2023. Key fact number 3, and this is really important and I think sits under everybody's radar, but it's really important from a public health perspective. And that is because of a number of factors. No more than 43% of the US population has a meaningful primary care relationship. You know, even if you look at people with the best health insurance available, that is Medicare, only 65% of people with Medicare have had a primary care visit in the last year. Even though, you ready for this, 89% of people with Medicare are on at least one prescription medicine. So you got to think about where that disparity comes from. And it is also the case, and I can talk about this later, the U.S. is likely short 200 to 300,000 primary care clinicians. So we just don't have the workforce we need to take care of the population that we have to serve. And that's concerning because primary care is the only medical service that's been shown to reduce costs while it improves public health outcomes. These data suggest that 57% of the US adult population is not getting evidence-based prevention. And think of the consequences. It's concerning because primary care and public health together has been amazingly successful over the last 100 years. We virtually eliminated polio, measles, mumps, rubella, and the many birth defects rubella caused. Nobody has seen a case of rabies in the United States for as long as anybody can remember. Those of us who have worked in the developing world have seen rabies and know what a disaster it is. We've virtually eliminated rheumatic heart disease. I'm old enough to remember the pistol shot bruit in the femoral artery that you hear when somebody's destroyed their aortic valve because of rheumatic heart disease. That's gone. And that's gone because of everybody who's out there taking care of patients. And whenever anybody has a sore throat, they come in and get a culture and get started on antibiotics. That's a huge primary care public health success that has changed the incidence and prevalence of disease in my lifetime, and I'm younger than Neil. And, you know, we have virtually eliminated, or not virtually eliminated, but we've saved 8 million lives by reducing smoking. We've started to control hypertension and diabetes. You know, we are not where we need to be in terms of treatment to goal, but even so, years of potential life loss to 75 from ischemic heart disease has dropped by 65%. Years of potential life loss to 75 from stroke fell by 47%. We've seen a 70% reduction in adolescent pregnancy. That's all of us working together with huge measurable public health outcomes. We messed up SARS and COVID-19, in my view. I think we've had 900,000 excess deaths, but we still saved 3 million lives and prevented 18 million infections. We likely save 50,000 lives a year by colon cancer screening, and that's colon cancer screening 43% of the population. If we got to 100%, we'd likely save more than 100,000 lives a year. It's concerning because primary care is actually fairly powerful in reducing health disparities. Can't do it by itself by any means, but primary care is associated with lower rates of all sorts of different stuff, all-cause mortality, cancer mortality, heart disease mortality, infant mortality, and with the disparities in that, even in the presence of income inequality. Primary care supply, however, is a weak predictor of Black mortality and the disparities that exist among the Black population because of the huge effect of racism itself. remembering that it is still, despite the advantages of primary care in terms of health disparities, remembering that the best way to reduce health disparities is still to provide safe and healthy housing to all Americans, improve public transportation, improve public education, and so forth. This loss of primary care penetration is concerning because primary care clinicians help mitigate some of the harms done by social dysfunction, by bearing witness, and by advocacy itself in terms of health disparities, in terms of unequal treatment, in terms of unhealthy housing, and mitigated through lead poisoning and water quality and asthma prevalence, because of our bearing witness to the health effects of homelessness and incarceration. And we really have been crucial to calling out the risks of substance use disorder and beginning to think about creating a treatment system using our primary care practices themselves. It's concerning because primary care actually helps people in a whole bunch of different ways by relieving pain, by mitigating suffering, by helping people preserve or restore function, by promoting the agency of individuals. There is magic that happens when a primary care clinician sits with the patient, listens to the person, and helps that person understand they matter, because that interaction helps people develop and maintain the strength they need to be active and present in the democracy and make the democracy not only work, but work for them. And because we end up being pretty effective preventing injury, preventing the loss of function, and preventing premature death, and thereby creating more equal outcomes. That's the way our impact on health disparities actually works, and it matters. And all of this really works because of the relationships clinicians have with the people who are their patients. There's a mound of data that shows the value of continuity over time, the value of time, of sitting time, of being with patients, the value of helping people, of understanding people's context and helping them see where they are in that context, and where they can go. And because of that focus on the individual, and the importance of that individual. And as a result, we actually lost life expectancy in the United States for 7 years, for 4 years before the pandemic started. The CDC will say that's because of COVID-19 and unintentional injuries and suicide and heart disease and chronic liver disease and cirrhosis as a consequence of hepatitis C. But when you really take a step backward, the distal causes of that loss of life expectancy, as I understand the world, is income inequality and its consequences, racism, and the shrinkage of primary care utilization. That so few Americans actually have primary care now. Remembering from a public health perspective, it's always about the denominator, and we have not adequately addressed the denominator because we just don't have enough folks to do it, and because the culture has mitigated against people using primary care in a consistent way. Fourth major key fact, and this is, I think, part of the mechanism of why what's happened has happened. Our colleagues in healthcare businesses spend $718 million a year on lobbying, which is 0.015% of the money they're making. It's budget dust to them. And yet that money helps them convince legislatures and Congress and other people in public policy to do what doesn't make sense and not to do what does make sense. The central what does make sense is to provide primary care to all Americans, which we have failed to do as long as I've been alive, and hopefully we will change that. But this money gets used not only to defeat the public health, but also in a deep way to upend democracy, because our representatives aren't doing what their constituents actually need because of the way money gets in their face. So at the beginning of the pandemic, I was helping build and run the first neighborhood health station in the United States. And that's a picture of it. It's a building in Central Falls, which was designed to have enough space to take care of the entire community of 20,000 with medical care, dental care, mental behavioral health care, physical therapy, lab, and x-ray all in one place. It was designed to be open from 8 o'clock in the morning till 8 at night and open on weekends. It was designed to be the model for how you guys already do primary care, and really provide care to everybody. But I didn't do what Dr. Kalman did. I didn't have the opportunity to help think about the organization and management of the community health center. So its leadership was all white and suburban, and it was very conservative from a kind of theoretical perspective. So the moment the pandemic hit, the neighborhood health station closed to new patients, which was a disaster because there were still 10,000 people in Central Falls of the 20,000 who didn't have primary care. So I worked together with the two mayors of both Central Falls and the neighboring city, Pawtucket, where together we probably had 50,000 people who didn't have primary care. In a state where the recommendation, if you got sick, was to call your primary care clinician, but half people didn't have it. So we together stood up a community-focused emergency operations center, brought in 18 community organizations, and in 2 weeks developed a kind of amazing call center that answered the phone in 4 languages: English, Spanish, Cape Verdean, Creole, and Portuguese, that asked only your first name, and you didn't have to give us the real one, and your cell phone number, because there are significant numbers, 3,000 to 5,000 undocumented folks in Central Falls. And we wanted to make sure they were comfortable. We got a volunteer clinician on the phone and helped people who were sick understand whether they needed the hospital or not. If they didn't need the hospital, we got medical students and pre-med students to do isolation coaching to help them understand, help people living in very densely packed apartments how to do isolation wherever was possible. We got people food, we got people disinfectants and masks delivered to their houses. We got people cash if they were undocumented, so they didn't have to go out to work through isolation. We got them over the phone mental behavioral health counseling. This thing worked like a charm. Like I said, got built in 2 weeks. We got 80,000 phone calls. 80% of the callers were or reported family incomes less than $25,000 a year, and or were non-English speaking. And as a result, and I can't say it's a one-to-one cause and effect thing, but it does happen to be the case that though Central Falls was the most infected place in the country, it also had the 6th lowest COVID mortality rate in the state of Rhode Island itself. So great success. You know, we did the best we could with what we had. We did it collaboratively. It felt great in a very tough time. It got to be May, and COVID community transmission rates started to drop. And we said, let's take this success and really carry it on. Let's use some of our public health tools, some hotspotting tools we have, identify the highest risk blocks, and then go to those blocks and test every single person in the block, identify the cases that are still circulating, get those people into isolation, and using a classic public health approach, stop the spread of the disease, and possibly postpone the coming fall surge that we knew would be there, and maybe help reduce the incidence and prevalence of the disease and its mortality, not only in Central Falls, but also in the state as a whole, because in a certain way, Central Falls is the canary in the coal mine, and in a certain way, some of the disease spreads from those places that are densely packed. Cool idea. We did some back of the envelope calculations. It was going to cost us $800,000 to do that for about a year. The state was getting $1 billion in federal aid. So the mayors called up the governor and said, can you just send us $800,000? We'll get this done. And all of a sudden, everything stopped. It stopped because all of a sudden there were complex negotiations. We had been having Zooms 2 or 3 times a week to keep this thing running. All of a sudden, all sorts of new people started showing up on the Zooms. Who were they? They were people from Iowa and Minnesota and Indiana, people we didn't know, young people, very nice people, people who didn't know anything about speaking Spanish, or people who spoke Spanish, people who didn't know anything about culture in Central Falls, people who didn't know anything about Cape Verde. They didn't even know Cape Verde existed. And let me tell you, they certainly didn't know anything about public health. Who were they? They were consultants. And where did they come from? Well, the state was paying a fair amount of money for consultants. It turned out it would pay $12.4 million in the first couple of months when they couldn't find $800,000 for us. This thing bubbled along until the state decided it would send not 800,000, but 175,000 to another contractor, not the cities, and our great effort then fell apart. So how did those consultants get there? Well, essentially the state paid them, but they also began to come, I think, and I think they were fairly highly paid, because that $13,000 per person per year is seen by some as an opportunity to create income and profit. I'd never thought about spending on healthcare as a resource, as representing the wealth of each community, but suddenly it occurred to me that maybe people were seeing Central Falls not as a place of need, but a place where there are resources that could be expropriated. And I began to understand that maybe the community spending on health actually represents a significant portion of the wealth of that community. And then and that is going to attract attempts to extract those resources. And in a certain way, the attempt to extract those resources sounded a lot like colonialism. It hadn't occurred to me before, but there it was. And I sort of said, well, could this be real? So that's when I got mad, and I started to follow the money and started looking at the economic impact of health services on communities. And this is what I found. First, 50 to 69% of the wealth transferred in the United States of the spending on healthcare are public funds. This is public money. I thought it was 50% when I ran my rough numbers. Adam Gaffney and Stephanie Wilhander and David Himmelstein just published that it looks like it's 69% of all our spending are public funds. And not only that, the transfer of wealth actually uses the government as an intermediary, mostly as a payer, but sometimes as a regulator, analogous to the way that the colonialists of old would use the government and its military to invade small foreign places and take them over and extract the resources from those small foreign places. Looked like it might be happening with these funds in the United States. And also, one begins to notice, and I was a regulator, so I know this, state and federal law regulates all aspects of healthcare service delivery. All healthcare in the United States is a public process, only for a variety of reasons. Think back to that $718 million a year people spend on lobbying. In a certain way, it's a public process, but it's a public process that's derailed so that it functions not in the service of the needs of the population of places, but it works in the service of folks who are out for profit and for income. Now, think about this, this breaks down segment by segment. Let's look at insurance companies. Think for a second about Medicare Advantage. Medicare Advantage is all public funds. Some of us remember when Medicare Advantage got started, the health insurance companies promised they would deliver all the healthcare people needed for 15% less than the government was paying for Medicare at the time. And so the government said yes. Some of us are old enough to remember how they used their lobbying might and played the game a little bit. And so now Medicare Advantage costs 6% more than we are paying for traditional fee-for-service Medicaid. Anyway, Medicaid Advantage has 27 million enrollees. It costs in 2019 about $12,000 per person per year. The insurance companies get to keep 15% of that. And when you run those numbers out, that's $48 billion a year of public money that's going into private hands, public money that represents the wealth of communities going into private hands to administer spending and doing it in a way that costs the government more than if the government did it by itself. $48 billion. Same process is true with Medicaid. Medicaid, Medicaid managed care happens in 41 states. It involves many more people. It was 54 million people in 2019. During the pandemic, it actually became more than 100 million people. Per person per year cost of Medicaid is far less than of Medicare, but when you run those numbers out, same basic calculation, the health insurance company keeps 15%. That's $47 billion or more. Understanding that each Medicaid program is a little different, but these are basic unifying concepts. When you put that together, that's close to $100 billion a year. And take for a second to think about what we could buy for $100 billion a year if we spent that money to build housing. You could build 285,000 two-bedroom apartments at $350,000 each, which is what it costs average in the world, not in the city, but city is a little more. But I think that gives us a sense that's enough to house over 1 million people. And guess what? In the United States, there are like 500,000 homeless people a year. Similar calculation, if we wanted to spend that money on training more primary care people, we can afford 1.3 million $75,000 medical school tuitions. Still costs way too much, but that means we can basically train about 300,000 extra primary care people a year, which is what we need. It's actually more than what we need. So we could split the difference for $100 billion and house the entire homeless population of the United States and train the primary care workforce. And if you want to understand part of why we don't have the money to spend on building housing and on training people, if we want to understand why everybody feels overworked, because we are, it's because this money that should be spent on housing and on the education of clinicians and about 10 other things is going elsewhere. You can run the same calculation on commercial health insurance. That's not public funds. And by full disclosure, but it's even more money than that is diverted to health insurance companies. Think about pharma for a second. Pharma is entirely FDA regulated. We spend about 20% of the whole total healthcare spend goes to pharma itself. And pharma is everywhere. As I said before, 89% of people over 65 use at least one prescription medicine. 54% of people over 65 use 4 or more. About 50% of the population uses at least one. We spend $378 billion a year on pharmaceuticals. That's about $1,100 to $1,200 per person per year. Now I'm going to come back to Little Scituate because I know the economics of the town pretty well. Scituate spends $22 million on our education system, on our schools. That means we have about 140 school employees, school department employees, who mostly live or near town and spend their money in town. And because of something called the multiplier effect, that money circulates in town and makes the town as a community financially more resilient and more stronger and more able to advocate for itself before state government and in front of the federal government and in other ways and places. Now, divide that number in half, because we spend half the amount of money on pharmaceuticals as we do on schools. So we might expect about 70 employees related to pharmaceuticals. We have one Walgreens drugstore. I called up the pharmacy manager to find out how many pharmacy employees we have. It is 8. So sort of by an apples to apples, oranges to oranges comparison, instead of 70 employees, we have 8. So the bulk of the money that we're spending on pharmaceuticals doesn't stay in town, doesn't recirculate, doesn't make us more resilient. It goes elsewhere, to wealthier communities and to profit. You can do the same thing, run the same analysis on research. It turns out that most research happens in cities. Biotech scientists actually make a fair amount of money. But guess what happens? The bulk of researchers are white men and white women. So that is an effective transfer from communities of color to communities of privilege over time, from urban to rural. I mean, from rural to urban, but even inside urban areas, from communities of poverty to communities of wealth. Certainly research has benefits, but it also has an economic effect which concentrates money from communities that are challenged into the hands of high earners. And if you want to look at research subjects themselves to see, whether that income is fairly distributed, well, it turns out we don't know anything about that group of people. Nobody studies it. I called up the FDA to try to learn what they know about research participation by race, community characteristic, class, language spoken at home. We don't know anything. Remembering that IRBs exist to protect individuals, but nobody's in charge of protecting communities and making sure that research income is distributed fairly. How about the economic impact of physicians on communities? We like to think we're better than anybody, but in fact, certainly specialty physicians are concentrated in high-income communities. And what that does is affect the same kind of wealth transfer that we see with research and with pharma. Understanding, and this is, I think, to me, this is the point that drives me particularly crazy. Remember that all residency training is publicly funded. Every single penny comes from CMS. So in theory, the specialty distribution is under direct federal control. And if we had what we needed to run a healthcare system, we could make sure that hospitals devote 70% of their training dollars to primary care. But instead, we just give the training dollars to hospitals and say you can divide it however you want. There are only a few places that have effective advocacy to make sure to protect as much of that as possible and get it into primary care training. But even so, it's nowhere near enough. And even primary care, it has now become it has awakened the interest of our venture capital and private equity friends. As you know, CVS just bought Oak Street for $10.6 billion. Amazon bought One Medical for $3.9 billion. The ChenMed market cap is $7.5 billion. That's recognizing the power of primary care itself to basically be instrumental in extracting extracting public funds from community, as painful as it is to see that. Even medical schools. I mean, look at the salaries of medical school deans. Even in publicly funded medical school deans are making like $1 million a year and more. And that's with only about a third of medical schools reporting. So my guess is that the outliers are making more, and perhaps way more than that, with private medical schools, deans making $2 or more million a year. And when you think about the economic and social impact of medical schools on communities, this references some of the amazing work Fitzhugh Mullen did when he was alive on the social impact of medical schools. But we are still in a very difficult situation where medical school students do not look at all like the community that they serve. It is still the case, 40 years down, 50 years down the line, that only 3% are Black men, half of the population of Black men in the population. And, when you compare that to what is happening in Cuba, not that I mean to endorse the human rights record of Cuba in any way, but it's still the case that there is one medical school in Cuba that takes U.S. citizens, has trained 170 U.S. citizens, is training about 90 now, and 50% are Black and Latino, where in the U.S. only 20% are Black and Latino, despite the disparities that exist, and despite the need that we have to desperately change those numbers so that our clinicians look like the communities they serve. So what do we learn by following the money? We learn that much of the economic activity around healthcare has in fact led to a net transfer of wealth from neighborhoods and communities into the pockets of corporations and shareholders. And that's across every single segment of the healthcare economy. Remembering as well that now 37% of healthcare dollars are spent on administrative overhead and not healthcare itself. We learn that healthcare in the United States is a public process, publicly funded. And, I forgot to mention that hospitals are 61 to 62% and sometimes more running on public money. I heard of one last week that's 75% running on public money. There is no effective public oversight. They are self-appointed boards. They do not look like the communities they serve in any way. And there is no data whatsoever that shows that the number and location of hospital beds has any impact at all on public health outcomes. That doesn't mean that they don't. The absence of evidence, not being evidence of absence. But that compares to primary care, for which there's a mound of evidence showing that primary care both is associated with improved public health outcomes and lower costs. This wealth transfer weakens communities and weakens democracy because communities no longer have the resource they need to fight for themselves. So where are we? We're not about profit for investors or siphoning money from communities. That's not what we all signed up for. And that's not what communities want or need. So what is healthcare for? What have we learned? Healthcare continues to be to be there to reduce the impact of disease and prevent disability. But I think the thing to learn from this is it's in a deep way also to promote agency, to give people and communities what they need to speak for themselves and fight for themselves. And so healthcare that is for people, not for profit, does more than just reduce the impact of disease and disability. Healthcare that is for people, not for profit, protects democracy itself. Our challenge then is to build a healthcare system that is for people, not for profit, and starts by providing robust primary care to all Americans in every American neighborhood and community. The miracle of democracy, to the extent it still exists, is that if the government can be used to strip away the resources needed to create health equity, then government can be used to put those resources back, just as Jack Geiger taught us 50 years ago. Government can be used to create optimal and equal health for all Americans. So what can we all do? Well, first of all, I think we need to talk to friends and family, help them understand that we have a market that extracts wealth and destroys agency, not a healthcare system. Every time somebody uses the word healthcare system in my presence, they get a diatribe from me, a gentle diatribe, trying to change the language so that people look at what we actually have. We can start talking to patients in the exam room, telling them the truth about what healthcare costs and why healthcare is expensive and difficult, that it's not there for their families and their communities, that it's there to extract wealth. And we have a desperate need now to talk about the importance of primary care and public health. We lost a huge amount of ground in terms of public support for public health during the pandemic. And we need clinicians to be there talking to people to win that trust and respect back. You know, everybody can invite a few people to dinner and begin to work in their own communities to choose a tiny winnable battle. I invite you to look on the net at the Situate Health Alliance and the work that's been done in Situate. We've done similar work around the state in Rhode Island around building local multidisciplinary teams. You pick one little battle, ask everybody to have a couple of meetings, feed everybody each time, ask everybody to come, to bring one more person each time they come, fight that little battle, win the battle, and have a big party and then repeat it. And I think we're going to be able to come back in a couple of months and talk about something called primary care for all Americans. I think that's the social movement we need to build. A couple of us are beginning to work on building it. We're going to need everybody's help and participation. I had the huge honor, not only of knowing Neil, but also of knowing Dr. Bernard Lown. Dr. Lown was a world-famous cardiologist. He invented the defibrillator. He invented the contemporary treatment post-MI. He's named, or his name shows up on the second most important pre-excitation syndrome after WPW, Lown-Levine-Ganong. But when he got to his 60s, he realized all the cardiology he was doing was going to be useless if we had a nuclear war. So Bernie helped organize international physicians to prevent nuclear war, and for that, he won the Nobel Peace Prize in 1985. I had the amazing opportunity to know him and actually get pretty close to him. And he had a saying that I think is really useful, which is, if you see the invisible, you can do the impossible. I hope in the last hour you've had a little look at what may have been previously invisible. So now together we can do the impossible. I'm from Rhode Island, where we have both a state flag and motto and a state bird. The state flag teaches us it's okay to hope, as long as you're not too chicken. Thank you.
Oh, amazing, Michael. What a piece of work. Every place you look, the concepts that you're talking about are reemphasized. And after I watched your grand rounds online a month or so ago, I was like, oh my God, this guy's got to come and do grand rounds here. Two things popped up that I think were just completely relevant to what you said. One you mentioned, which is the fact that we train all of these doctors using public funding. The interesting thing to me is that we don't connect that with any kind of public accountability or responsibility. Not only can they go into whatever specialty they want, no matter how oversubscribed it is, but we don't extract any service requirement from them. So we pay them as residents for 3 years, sometimes for 6 years or 7 years, using all the public funds, whether it's just CMS for 3 years supporting the residency, or through Medicare and Medicaid dollars supporting all the residents really when they come to the hospitals. We don't ever ask them. They can graduate after all of that training and decide the day they walk out that they're never going to see an uninsured patient or somebody covered with Medicaid.
And too often do.
And so in New York, we see that all the time. Doctors coming out at Mount Sinai who won't take any kind of Medicaid coverage, and we've paid for their training with public funds. But this week in the Times, there was a great article that basically said 50% of all of the funds that are used to develop new drugs come from the public through NIH dollars and everything else. At the end of the day, that lobbying money that you showed, the lobbyists have been so powerful for pharma that they've been able to pass laws that say that Medicare and Medicaid can't negotiate prices. So we literally pay for the development costs, 50% of all the development costs with our tax dollars. And for that, we get a system where the publicly funded folks who need medications, we've strapped them and we've tied their hands, and they cannot negotiate prices. So let's see if there's some questions. I see a comment in the chat. I want to remind everybody that we have negotiated with Michael's help with his publisher, and we've been able to get copies of the book. Anybody that wants a copy of the book on medicine is Colonialism, send a note to Eric Wildstein in the department, or to me if you don't know Eric's email. Oh, there it is. Eric's email address. Just send us a note. We're going to be purchasing copies of the book for everybody that wants one. And second of all, if you have, I see one question in the Q&A. Great insights. Eugene, are you on? Can you just ask the question? Well, I'll read it. Great insights and reflections to review our healthcare market and system. Can you speak to the role of profit-oriented EMR companies driving up costs in the digital divide, even in primary care? I find myself trying to help at least a dozen people each week try to open up EMR patient portal accounts to access health records who have low health literacy, don't even have that easy access to email addresses required to sign up.
Oh, what a great question. What a hustle. In 2009, the United States spent $19 billion on the private development of EMRs to kind of make EMRs generally available. And what a disaster they are. These EMRs are billing processes. They've helped download the whole billing process onto the back of clinicians. Our colleagues in other countries love their EMRs because they're clinical. They're there to help them take care of patients. And yet we all hate them, and they're a huge burden for us because they're there to run the billing process. I keep looking for the day when we find a way to resist, and we've got to, because in a certain way, we've all been a little complicit because we kind of went along with it. We went along with it, kind of led by noble aspirations, but because, nobody can read our handwriting. But what we got was one continuing disaster. And one of the things that we need to do is we build a social movement to change this, is to change that and get us an EMR that's for patients and for patient care, not to generate profit from others. And we got to resist this download of coding, which exists only to make work for us and profit for others.
Thanks, Michael. I want to ask you for some help with something that we're sort of struggling with. So the Medicaid waivers that go on that created like the PPS system that failed miserably to do anything to transform healthcare for 5 years, that we got billions of dollars in New York. So the new one is basically proposing the same thing, except it's built on a model where primary care folks are going to be screening everybody that they see. And so are managed care companies for what has been called social determinants of health. So, the concern I have is that we've seen this with depression and everything, where we screen people for depression and have resources to care for about a fifth of the people that need behavioral health care. my concern is that when you talked about housing and stuff like that, we're putting all of this, we're giving all this money to healthcare providers, have them screen for stuff, but without any resources on the other end for people to actually be helped. Like, shouldn't we be putting the money into the housing directly and not into like screening people and asking them what do you really have a problem with housing? Because then we refer them to agencies that really don't have any resources to provide housing. And I don't know, people are really torn about whether or not all this social determinant stuff belongs in healthcare at all, or whether we really need to build the social system alongside of healthcare that really helps people with these things. What are your thoughts on that?
Oh man, do we agree? I mean, I think the social determinant approach has been totally mangled by our colleagues at CMS and others, trying to download responsibility with no control, as they've done a number of other times. And we need to find a way to resist it because it's completely wrongheaded. As you said, screening without access is a total waste. U.S. Preventive Services Task Force has been saying that for 50 years. So, the solution to housing, the solution to the housing problem is to build public housing. It's not to screen people and refer them to people who can't do anything. I've seen it taken to absurd degrees, where not only do people have to be screened, there are folks who say, well, if you see somebody who's housing insecure, you have to write a referral, like you write a referral to a specialist, and then you have to track the referral to make sure that the loop got closed. That's a useless set of exercises that just is there to make some bureaucrat feel better. Our value in social determinants is our ability to be public advocates for problems when we see them, to call out those problems and speak to them publicly to get the kind of social change we need so that we build public housing and we improve public education and improve public transportation, but not to do it patient by patient. That's got no sense to it.
Well, that's what New York State has proposed for their new $7 billion waiver for CMS. And I fortunately, I think we're getting a little bit of a hearing with people at CMS because they've been postponing approving the waiver for the last 7 months. And finally, I was on a call with both the CMS director and the director of Medicaid in New York about 2 weeks ago, where CMS basically looked at them and said, this is not how we want to spend $7 billion of government money. So I think the message might be starting to get through that, we have to stop pumping money into this old system that's really not, producing any kind of results. And from my perspective, we still have a lot of ways to go to do a better job at primary care before we start putting the whole burden of social stuff on them. There's a new question. It says, same for mental health. We do so much screening, but we have very, very little access to mental health care. It all falls on primary care providers. Absolutely.
Yeah. I mean, we need to be investing in training mental health clinicians. We need to be taking this money and using it to build new medical schools and build new residencies. We probably have to quadruple the number of medical schools we have to meet the need, understanding that the ideal patient panel size has probably dropped fairly significantly because of all the work our bureaucratic friends keep dreaming up for us, like that social determinant screening and so forth. We got to spend the money where it makes sense, where it's going to have impact, instead of doing something just to do it. Like trying to extend a system or a process that might work, sort of a little bit for medical consulting, but isn't going to work in the same way for mental health when there aren't enough clinicians for substance use disorder treatment, when there's no real treatment process. I mean, I don't know how it is in New York, but in Rhode Island, we desperately need treatment on demand for substance use disorder. We don't have anything even close to it. That's what we got to spend our money on.
Yeah. Well, we're well on our way to try to continue to build our footprint in primary care training, and especially in family medicine. And so Red Schiller found out that right now we're the 6th largest producer of primary care, of family doctors in the country. And when our new Brooklyn program opens up in a couple of years, I think we're going to move to number 2. So it'll
How cool is that?
yeah, it's very cool. And I think and more than that, I think we need to be teaching everybody the things that you taught us today, and that this should be part of our regular curriculum, because people have to understand the way the system works. If we're not just going to be producing doctors who just, are going to be repeating the same things, because we have to struggle against the system. It's as frustrating and as sometimes demoralizing as it is. If we're just in it and we just do it, and we realized all along that, it's failures to correct the things that you're talking about, then you walk away frustrated, but you don't really feel like you've changed something. And so we spent a lot of time trying to change the frustrations and the things that happen in the organization, in our interface with the rest of the healthcare system. But your analysis today really, I think, is just profound. And I hope everybody takes the time to read the book, and that we become part of the movement that you're trying to create. Red, did you want to say something?
Yeah, thank you, Michael. This is great. Can you hear me?
Yeah.
I think taking this to the next step of how do we become competent and more effective advocates? I mean, there's an opportunity. I mean, much like we're talking about, we want to get back to primary care and not do all these other screenings that are unnecessary. This sort of marriage between primary care and public health, really creates a need for developing a curriculum to get faculty and students and even the support staff in all of our community health centers to help people understand the role that this is really part. I think what you said is really helpful. This is part of a successful democracy. This goes even beyond public health.
Yeah,
So,
we are not just healthcare workers. We are essentially defenders of democracy, and we need to understand and see ourselves that way. Neil and I had the opportunity to have Open Society Institute fellowship years ago. And that was what George Soros was thinking when he gave us those, that health professionals have a unique role because our job is unself-interested advocacy. And we need to take that role, focus on it, and expand it. Now, I want you guys not only to do the amazing work you're doing with residency, I want you guys to start opening a new medical school in each borough, because we really need them. And there's nobody better than you to design them and build them out. So we select the right people. We select people from all our communities. We make sure that the people we're training look like the communities that they serve. Boy, that's part of our future as well.
Well, we have to stop. Thanks again. We totally appreciate you, not just the grand rounds, but all the work that you continue to do, and the way that you have just spent a life of shaking things up and creating a new way of looking at things that we all see every day. So you're one of a kind. We love you. Take care, Michael.
Right back at you. You guys lead the country, and we are so grateful for you being there and doing what you do.
Thanks. Have a good day, everybody.